everyone, and welcome to a new session of clinical pharmacology. In the previous session, we spoke about the peptic ulcer disease under the chapter of gastrointestinal clinical pharmacology. The second part of the GI system clinical pharmacology, we are going to speak about gastroesophageal reflux disease or gastroesophageal reflux disease, GERD. Okay, starting with the definition of gastroesophageal reflux disease. Gastroesophageal reflux disease, which has another name, GERD, include all consequences of reflux of acid or other irritant from the stomach into the esophagus. So any acid or maybe liquid or any substances return from the stomach to esophagus may consider like reflux or GERD. Gastroesophageal reflux occur when the lower esophageal sphincter LES is lower than intragastric pressure. So when you have pressure in the esophagus lower than the pressure in the stomach, this will allow the acid to return back to the esophagus and cause the irritation or the complication, such we are going to see it in the signs, symptoms, and other maybe manifestation of GERD. Let me share this website with you for a few seconds and to see what happened there. If you move down a little bit, scroll down, so you can see what exactly is the acid reflux. This is a normal healthy stomach, and you can see the sphincter here, lower esophagus sphincter, closed properly and does not allow the content of the stomach to come back again to the esophagus. But with the patient with the GERD, you can see some content of the stomach return or come back again to the esophagus and cause the irritation or may cause ulcer sometimes. Okay, in patient with the GERD or gastroesophageal reflux disease, you can see here what we have. We have the case when we have acid reflux of the stomach content causes troublesome symptoms more than 2 weeks or complications. So could be symptoms, could be complications. And the situation here related to the decreased lower esophageal sphincter pressure, LES, and sometimes we have disruption in the anatomical barrier, and at the end we have delay gastric empty. So could be one of these, could be that target for therapy for us. For example, we can use some medication to enhance the cardiac empty, for example, or we can use some medication to increase the esophageal sphincter pressure. Okay, or we can go with some surgery to correct the anatomical abnormalities. Also here we need to take on consideration some other factors. Okay, so we need to take in consideration some other factors. So for example, drugs sometimes may cause GERD. Food, sometimes smoking, and play a significant role in GERD. So some of these medications some drugs that lower esophageal pressure. We have calcium channel blocker, CCB. We have nitrate, and we have anticholinergic medications such as tricyclic antidepressant and antihistamine. Antihistamine, here we talk about first generation, especially antihistamine. Okay, so and other oral contraceptive. So we have some medication may involve in the maybe induce or accelerate symptom of GERD, calcium channel blocker, nitric oxide, anticholinergic medications such as antidepressant, tricyclic antidepressant, and antihistamine, and some oral contraceptive medication. Food, sometimes such as chocolate, fatty food, onion, peppermint, garlic, all these food may enhance or reduce LES tone and cause the GERD. Smoking sometimes reduce the tone of lower esophageal sphincter. So all these factors considered like important maybe items should be taken in consideration when you diagnose GERD or peptic ulcer disease. The patient may suffer from heartburn, but the patient may suffer from regurgitation, hypersalivation, salivation, belching. Sometimes the patient suffer from extraesophageal syndrome, such as chest pain that with they lead to the misdiagnosed with a heart disease, angina, or MI. Patients sometimes suffer from cough or asthma. Patients sometimes suffer from dental and enamel erosion, hoarseness, and all these related to the extravageal symptoms, not related to the esophageal. Sometimes we have complication. Sometimes we have complication of the disease, and you can see here patient may suffer from complication like esophagitis, structures, esophageal adenocarcinoma, and difficult swelling, dysphagia, losing weight, and GI bleeding. So you can see the symptoms could be like GI symptoms like heartburn, regurgitation, or extrapyramidal symptoms, or like complication of this disease. Okay, so the management of GERD involve two section or includes two section non-pharmacological approach and pharmacological approach. Speaking about pharmacological approach, you can see here we have lifestyle modification. Non-pharmacological approach, lifestyle modification recommend patient to avoid large meal, avoid lying down within 3 to 4 hours after meal, avoid acidic food like tomatoes, alcohol, caffeine, chocolate, onion, garlic, peppermint, avoid clothing that is tight around the waist, avoid medications that potentiate the GERD, such as calcium channel blocker, alpha antagonists, thiophyllene, nitrate, and what we have here, sedative, some NSAID. Try to avoid this medication in order to prevent from the GERD occurrence. Decrease fat intake. Elevate the head of the bed around 4 to 8 inches. And if the patient is from obesity, we encourage patient to lose weight. Okay, in this slide, we try always to recommend the patient to take the medications in the sitting position, sitting upright, or standing position, with plenty of liquid, especially in those who have direct irritation with the medication that have direct irritant to the esophagus membrane or mucosa. So recommend patient to take it in the sitting upright, standing position, and we have some medication considered like having the direct irritant to the mucosa, esophageal mucosa, such as bisphosphonate, tetracycline, quinidine, iron, aspirin, and other NSAID. So we have a group of medication have direct irritant effect on the esophageal mucosa. Treatment, this is our topics here, and this is the important one related to the topics for the clinical pharmacology. We can go with the antacid, the same will be applied. So in this one here, antacid, I will refer you to the lecture related to the peptic ulcer disease already recorded and published. Antacid, appropriate initial therapy. What happened there? They said it's like more effective than placebo. If you compare antacid with the placebo, antacid more effective in management of GERD compared to the placebo. That's great. Then we move to the H2 blocker, histamine H2 blocker, H2 antagonist. They said this medication prevent acid secretion and more effective than antacid. More effective, please remember that. So we have antacid more effective than placebo. H2 blocker more effective than antacid. Okay, then we move to the proton pump inhibitors. Proton pump inhibitor, as you can see here, stop the production of acid more completely than H2 blocker. So if you have it there, you take which one is the more effective here. We are going to write it down. PPIs more effective than H2 receptor blockers, and H2 receptor blocker more effective than antacid. Okay, so this is the efficacy. We are talking about the efficacy of medication. Which one more effective? PPI, H2 blocker, and acid, the efficacy. Okay, so sometimes we can use a coating agent or protective agent such as sucralfate, okay, to provide protective barrier for against the stomach acid. Okay, so at the end here, what we have, last one here, we try to use bromotility agents. Bromotility agent, and the purpose of this one to help, in order to help tighten the lower esophageal sphincter. So this one, lower esophageal sphincter, this medication, group of medication, enhance motility, enhance sphincter tone, provide, in this case, promote empty of stomach. So we have two things here. Number one, help tighten the esophageal sphincter and enhance empty of stomach. So two function, tighten and enhance empty of stomach. We have list of medication: bethanicol, neostigmine, and metoclopramide, domperidone, and erythromycin. So list of medication could be used, but not all these in the clinical practice. But this medication maybe have the effect of enhancing the increased tone of lower esophageal sphincter and enhance empty of stomach. Bethanicol belong to the cholinergic agonist. Then we have neostigmine considered like and acetylcholinesterase inhibitors, which lead to the enhanced effect of acetylcholine or acetylcholine. Then we have metoclopramide, domperidone, and this medication considered like dopamine antagonist, dopamine 2 antagonist. Okay, so we have dopamine 2 antagonist, two medication, metoclopramide, domperidone, and the last one will be erythromycin. Erythromycin belong to the antibiotic called macrolide, and we have the only one here, and we are going to speak about that in the next slide. Now we have three group of medications. Number one, we have antacid, then we have H2 blocker, then we have PPI. Then they start talking about combination of treatment between H2 blocker and antacid. So we have four options. The question now, looking on the onset of action, which one from this slide here, which one is like considered like fast onset of action? When the patients suffer from GERD, okay, and suffer from symptoms, epigastric pain, and increased secretion of acid. Which medication will be the fast medication? What do you think? Do you agree with the antacid will be the fast medication? Okay, which one will be the lowest onset of action? PPI, take 2-3 hours. Okay, then speaking about the duration of action, which one considered like longest duration of action? So what do you think? Longest duration of action. PPI will be longest duration of action, 12 to 24 hours. Which one the shortest duration of action or short duration of action? Okay, 20 to 30 minutes. So when you take antacids such as Maalox or other medication, aluminum or magnesium hydroxide or calcium or sodium bicarbonate, so this medication start work after 5 minutes and remain in the effect for 20 to 30 minutes. But if you take PPI and the patient suffer from annoying symptoms, this medication need 2 to 3 hours to start working. If you need the effect of this medication directly, go with antacid. Okay, so this medication lasts for 12 to 24 hours. Okay, moving to the other situation here. What about H2 blocker? Histamine 2 H blocker. So what we have here is this medication start working after 30 to 45 minutes and remain for 4 to 10 hours. Okay, so in the practice they said, okay, what happened if combine antacid blocker, H2 blocker with antacid? So what happened if you combine H2 blocker with the antacid? In this case, we achieve maybe rapid of action due to the antacid, rapid of action, and we achieve the long duration of action. Okay, so we can maybe in this combination treatment here, this will lead to the enhanced effect of medication. Two medication is one of the most important medication for GERD and also for the vomiting. Okay, vomiting and GERD. So we have metoclopramide, and domperidone. Metoclopramide, domperidone, this group of medication considered like dopamine antagonist. To be more precise, consider like dopamine D2 receptor antagonist, because we have D1 receptor, we have D2 receptor, then we have D3 receptor, D4 receptor, and we have D5 receptor. So we have 5 type of the dopamine receptor. The metoclopramide and domperidone block D2 receptor, consider like dopamine receptor antagonist on the D2 receptor. Okay, so what happened there? And these two medication here, the NGIT, this medication work on the stomach and activate. Okay, before we talk about this medication here, they said in the GIT, activation of dopamine receptor lead to the inhibit of cholinergic neuron. Okay, so here we need the student to be familiar with the following concept. I will maybe explain it on the whiteboard. Okay, so we need you to go back and maybe review the autonomic nervous system. Okay, so speak about autonomic nervous system here. We have two main systems. We have parasympathetic system. We have sympathetic system. Talking about sympathetic system, here we are speaking about epinephrine and norepinephrine. Also, we have dopamine. Parasympathetic system, the main mediator there, acetylcholine. Acetylcholine affects muscarinic receptor and nicotinic receptor. Nicotinic receptor, we have M1, M2, we have M3, we have M4, and then we have M5. All these considered like receptor for the muscarinic receptor. We have five type of muscarinic receptor. Okay, this is number one. So now we are familiar. We have muscarinic receptor. Speaking about muscarinic receptor, and we are speaking about the GIT system. GIT system, we need you to remember two things. So the muscarinic receptor, if you activate this receptor, this is the normal response. When you activate muscarinic receptor in the GI system, we have two main responses. The first response, increase secretion. So here we start talking about diarrhea, for example, or vomiting. Okay, and next we have increase smooth muscle contraction. Okay, we talk about abdominal pain, or sometimes we call this one like colic. So the effect of the acetylcholine on the M receptor, this will be increase secretion and cause contraction. So two things. Okay, I will go back to the slide again. Okay, so our medication here, try to explain to us what happened there. Again, I have to go there for 1 minute. So what they said there in the slide, they said dopamine receptor. When you activate dopamine receptor, this will inhibit acetylcholine. Inhibit acetylcholine. What happened there? If you inhibit acetylcholine. So here before we go on in details. Here we mentioned something about increase smooth muscle contraction, but we need to differentiate between two types of smooth muscles. If you speak about the smooth muscles, and I will go with the green color here. This is the smooth muscles. Okay, this is considered like longitudinal smooth muscles. Longitudinal smooth muscles. Okay, longitudinal smooth muscles. But if you look on for example, if you speak about the The stomach, for example, I'm to speak about the stomach, and in the stomach we have a sphincter here, and we have another sphincter here, LES. And this sphincter considered like circular muscle. Circular smooth muscles. Okay, so we have now, start talking about longitudinal smooth muscle and circular smooth muscle. Does that mean anything for us? Yes, because what they said there, acetylcholine, if you activate acetylcholine, activate the muscarinic receptor in the GI system, GI tract. If you activate acetylcholine there, the result will be contraction of a longitudinal smooth muscle, contraction of longitudinal smooth muscles, and relaxation of circular smooth muscle, relaxation of the sphincter. So that will mean that's like good effect for the what we have there. So acetylcholine causes contraction of longitudinal smooth muscles and enhances sphincter tone. Okay, that's what the effect of acetylcholine. So now we understand what happened there. If you go back a little bit or minimize it a little bit, so you can see here the effect of dopamine, dopamine receptor. The dopamine receptor maybe practice negative effect on acetylcholine. So if you activate dopamine receptor, the result will be inhibitory effect on the acetylcholine. Okay, metoclopramide. This medication used for GERD. Okay, metoclopramide considered like dopamine 2 antagonist, inhibit dopamine. This will lead to activate the opposite effect. You can see it here. Is if you activate dopamine receptor, the result will be inhibit acetylcholine. But if you inhibit the acetylcholine, this will lead to the activate and potentiate action of acetylcholine, and this we are going to see the opposite now. You can see the opposite now. The opposite will be what we have here: relaxation on longitudinal muscle, relaxation. Okay, and the other hand, what we have there, contraction of sphincter. If you can contraction of sphincter, and this enhances the tone of sphincter, lower esophageal sphincter. For this reason, now we can explain what happened there. I will go back again to the slide to show you what we have. Okay, so you can see here in reality, in normal healthy patient, in normal healthy subject, dopamine inhibit cholinergic. Dopamine inhibit acetylcholine. This is a normal. But with a metoclopramide block this effect. The result will be the opposite. The result will be, now when you block the effect, the result will be enhanced acetylcholine. For this reason, the sphincter tone will be enhanced. Okay, metoclopramide, domperidone, both of them increase esophageal peristaltic amplitude, increase lower sphincter pressure, and enhance gastric empty. This is a very important effect for the both medication, domperidone and metoclopramide. Speaking about the clinical use of this medication, metoclopramide, GERD, gastroesophageal, we have GERD. Then we have patients suffer from diabetic gastroparesis. Gastroparesis defined as partial paralysis of the stomach in patients with diabetes, and this medication used for preventing or prevention of vomiting. So we have 2 or 3 clinical use. Number 1, GERD. Number 2, diabetic gastroparesis, and number 3, prevention of vomiting. Moving to the side effect. This is the most important profile for the metoclopramide. You can see metoclopramide adverse drug reaction. They said metoclopramide will be able to cross blood-brain barrier. For this reason, this will inhibit dopamine receptor in the brain. When you inhibit dopamine receptor in the brain, the result will be induce extrapyramidal symptoms. Okay, extrapyramidal symptom could be like agitation and like akinesia, dystonia, tardive dyskinesia, we have a lot of side effects related to the metoclopramide. Number one. Number two, metoclopramide found that metoclopramide increased level of prolactin. So when you inhibit dopamine receptor, the result will be extrapyramidal effect and elevated level of prolactin due to the effect on the prolactin hormones and on the brain, and the patient may suffer from galactorrhea, gynecomastia, and impotence. Okay, if you talk about women, the woman may suffer from menstrual disorders. So you can see here we have two main side effects related to the dopamine. Number one, extrapyramidal effect. Number two, elevated prolactin level, and the patient may suffer from galactorrhea, gynecomastia, impotence, and menstrual disorders in females. And the main reason for that, because metoclopramide able to cross blood-brain barrier, block the dopamine receptor in the brain and cause this effect. So if you click on the link here to maybe share with you what happened there in the so we can look on the metoclopramide information leaflet. I will try to maybe focus on the side effect for this medication and the clinical use. This one, like 20 pages from the metoclopramide, Reglan. So you can see it here with the maximize. We have it for oral use tablets. You can see it together. A warning and of tardive dyskinesia. Okay, this medication may cause tardive dyskinesia, a serious movement disorder, and is often irreversible. So if you are interested and knowing what is tardive dyskinesia, you can copy this name here and put it on Google or YouTube and maybe learn more about tardive dyskinesia, but this can lead to type of disability in the person. And again, for the medication or clinical use, you can see this medication and for metoclopramide. Okay, this medication used for treatment of esophageal reflux. Okay, this medication used for treatment of esophageal reflux. Also, this medication could be used for diabetes, gastroparesis. Okay. Okay, now move to the next medication. So we discussed metoclopramide, side effect, prolactin, extrapyramidal effect. Moving to the domperidone. What happened to the domperidone? They said domperidone is well tolerated, extremely well tolerated. It's very nice to have this medication, and this medication, why this medication well tolerated? Because this medication unable to cross the blood-brain barrier. This medication does not cross blood-brain barrier. Therefore, we don't have extrapyramidal effect or prolactin elevation or something like that. So for this reason, we prefer to use domperidone more than metoclopramide. But both medication belong to the dopamine D2 antagonist. This medication mainly work on the peripheral, okay, on the GIT system. Okay, we have the case here for 50-year-old male chief executive officer CEO presented to the emergency department. Highlight. Okay, so we have 40-year-old male maybe presented to the emergency department, experience from chest pain extend to the neck despite normal electrocardiogram and negative troponin test that exclude the angina. Okay, the patient diagnosed with the GERD, gastroesophageal. Consequently, he was discharged with the prescription for medication that block stomach acid secretion. So this medication, okay, the medication blocks stomach acid secretion. And what is the name of the drugs that permanently block hydrogen potassium ATPase in the parietal cell? And so what we have here, and for this question here, I refer the audience to review the peptic ulcer disease lecture. So peptic ulcer disease lectures, we explain in details the group of medication. For example, we discuss PPI, we discuss H2 blocker, H2 receptor blocker. We have discussed the antacid in details. Please review this lecture before you answer this question, for example. So moving to this possible answer here, could be which one inhibit the pump? Diphenolate, no. Cimetidine considered like H2 blocker, it's not cimetidine. Sulfasalazine, this medication used for patients from ulcerative colitis. What we have, metronidazole, mainly for Helicobacter pylori. We discussed that with the peptic ulcer disease. So the correct answer will be esomeprazole, that inhibit proton pump. So esomeprazole considered like PPI. So the correct answer is esomeprazole. Okay, at the end of this lecture today, brief lecture around 30 minutes, let me share with you a website from ResearchGate that maybe present guidelines for the GERD. And they said in this published article, they said if you have GERD, depends on what type of the degree or the severity of GERD, could be mild, moderate, or severe. Step 1, go with the lifestyle modification, dietary change, non-systemic therapy, antacid or alginate. This is first approach. Then second, we go the sucralfate, and the third option will be H2 receptor antagonist, except ranitidine, because already maybe we have some warning about ranitidine. And step number 4, they recommend use proton pump inhibitor there. So we have different approach for the case there. So at the end of this lecture, I would like to say thank you for everyone and have a great day.